We'll talk about the radiological anatomy of the lower limb. The femur is the longest, strongest bone in the human body. It is composed of head, neck, shaft, greater trochanter, and lesser trochanter. The head is globular and it is directed caudally, medially, and anteriorly. Its surface is smooth and coated in cartilage, except for the ovoid depression, which is the fovea capitis femoris, which is situated a little below and behind the center of the head. The fovea allows the attachment of ligamentum teres of the head of the femur. So this is a plain X-ray frontal showing the head of the femur. This is the neck, the greater trochanter and lesser trochanter. This points to the fovea. The blood supply of the femoral head. The femoral head receives its blood supply primarily from the medial femoral circumflex artery at the neck, with its deepest branch being the most important. Also, there's vessels in cancellous bone from shaft, vessels in capsule of the hip joint, small supply from fovea, from vessels in ligamentum teres. So this is a diagram showing the head of the femur, the neck, with the lateral femoral circumflex artery, medial femoral circumflex artery, supplying head and neck with the branch of the obturator artery. This is the head in normal, and this is the head in a vascular necrosis. So if there's a fracture of the neck of the femur, the blood supply through the ligament becomes crucial. Where this occurs, there's a risk of insufficient blood supply to the head, and hence a vascular necrosis may occur. So this is a frontal X-ray showing the fracture neck of the femur, where the red arrow points, and this is a vascular necrosis. Neck of femur. It is a 5 cm long anteverted that is directed anteriorly at an angle of 10 degrees with the sagittal plane. Also, it forms an angle with the shaft ranging from 125 degrees in female and 130 degrees in male. So this is a normal hip with the angle of the shaft ranging from 120 to 135. More than 140, this is a coxa vulga, and less than 120, this is a coxa var. Normal X-ray anatomy. So the X-ray of the hip showing the Shenton line, which is a line formed by the medial edge of the femoral neck and the inferior edge of the superior pubic rami. So loss of contour of the Shenton line is a sign of a fracture of the neck of the femur. Fracture of the neck of the femur does not always cause loss of Shenton line. The greater and lesser trochanters. The greater trochanter is a large, irregular, quadrilateral eminence attached to the proximal end of the femur. It is directed laterally and posteriorly in adult, and it is about 1 cm lower than the femoral head. It is of 2 surfaces and 4 borders to which several muscles are attached. The lesser trochanter is a conical eminence, which is of variable size. It projects from the posterior surface of the neck of the femur. This is the lesser trochanter. The intertrochanteric crest, like the greater trochanter, is also involved in muscular attachment. This is the intertrochanteric crest. The femoral shaft is almost cylindrical in form, is a little broader superiorly and slightly arched, such that it is convex anteriorly and concave posteriorly, where there is a strengthened by a prominent longitudinal ridge of bone posteriorly. This is the linea aspera, which splits inferiorly into medial and lateral supracondylar lines. Between them is the popliteal surface. The lower end of the femur is extended into two prominent condyles, united anteriorly as the patellar surface, but separated posteriorly by a deep intercondylar notch. The most prominent part of each condyle are called the medial and lateral epicondyles. Above the articular surface on the lateral side is a small depression that marks the origin of the popliteus muscle. So this is a diagram showing the anterior and posterior view. This is an anterior and posterior view. This is the shaft of the femur. This is the medial and lateral epicondyles, and this is the patellar groove. This is the posterior view with showing the linea aspera. Okay, this is the medial and lateral epicondyles, medial and lateral condyles, and the intercondylar fossa. Radiological feature of the femur. So the alignment and bones, the characteristic of normal proximal femur demonstrated on AP pelvis, as the head of the femur should sit in the convexity of the acetabulum with an even joint spacing. The femoral neck should have a smooth, intact cortex, normal trabecular pattern, and no transverse area of sclerosis. The intertrochanteric region should be identical to the same area of the opposite femur, no black or lucent line crossing the intertrochanteric region or the cortical margin of the greater trochanter. An avulsion of the trochanters, isolated greater or lesser trochanters, can occur following trauma. The line of Klein is a line drawn along the lateral aspect of the neck of the femur. The line should intersect with the superior femoral epiphysis. So the red line indicates the normal line, while the orange line indicates abnormal. So the alignment of Klein's line is disrupted with the slip. The epiphysis is malaligned with no intersection of the capital femoral epiphysis. Series of the femur. So the typical series for femur is the anterior and lateral views. This is the anterior view, AP view, showing the femoral head, the neck, the greater lesser trochanter, also showing the bone density, the cortex. This is the view for the AP view. This is the lateral view with an angle of 20 degrees, showing the lateral view of the upper proximal femur, showing this is the acetabulum, this is the femoral head, this is the neck, this is the greater trochanter, and this is the lesser trochanter. This is the lateral view of the distal femur. So this is an AP and lateral views. This is the distal femur showing the lateral and medial condyles. This is the patella, and this is the adductor tubercle. And this is an AP view showing the medial, lateral condyle, medial and lateral epicondyles, patella. This is the intercondylar notch and intercondylar eminence. The fibula is an accessory ossicle most always found in the lateral head of gastrocnemius muscle. Rarely occur at the medial head of gastrocnemius muscle, and it is approximately around 20%. The fibula also is a fibrocartilaginous in nature, seen projected on the posterior aspect of the lateral femoral condyle. Seen on ultrasound, this is an ultrasound showing the lateral gastrocnemius muscle with the fibula This is an AP and lateral view with the fibula here in red circle, and this is a red pointer to the fibula. Ossification centers of the femur. The primary center of the shaft appears in 7 weeks of fetal life. The secondary center is present in the lower femur at birth. This is a reliable indicator that the fetus is full term. Another appears in the head between the 6 months and to 1 year of age. Secondary centers appear in greater trochanter at 4 years and lesser trochanters at 8 years of age, and all fuse at 18 to 20 years of age. So this is an ultrasound image showing the femoral shaft. This is the proximal femoral epiphysis. This is the distal femoral epiphysis. Ossification centers of the femur. The head usually develops in the first year, joined to the neck by 18 to 20 years. So this is an X-ray showing the head by 6 months, 4 years, beginning head to appear, and fuses by 11 years. So this is the head. The greater trochanter appears during 4 years. Okay, fuses with the shaft after puberty, and lesser trochanter fuses with the shaft soon after puberty. So this is the last to appear after puberty. Thank you for listening. This is the part 1 of my lecture. The second one will be presented by Dr. Furqan.
أستاذ أبدي.
تفضلي.
هي تكملة للبونز of the lower limb. Patella. This is a sesamoid bone in the quadriceps tendon that continues at its apex as the ligamentous patellae. The upper 2/3 of the posterior surface is covered with articular cartilage and is entirely within the knee joint, and its anterior surface is covered by the prepatellar bursa. The lateral articular surface is usually larger than the medial surface. It forms part of the knee joint and extensor mechanism of the knee. This is the patella and the quadriceps muscle and tendon, and this is the patellar tendon. Wiberg classification of patellar shape. We have in this classification 3 types. Type 1, medial facet equal the lateral facet. Type 2, when the lateral facet is slightly larger than the medial facet. Type 3, lateral facet is dominant and medial facet is atretic and redundant. In type 3, we will see that more commonly associated with tracking disorders and transient subluxation. Wiberg's classification, type 1. Here we see that the lateral and medial facet of the patella is equal. In type 2, we see that the lateral facet is larger than the medial one. And in type 3, the lateral facet is dominant and the medial is atretic and small. This is the normal healthy patellofemoral joint. And here we see the subluxated patella. More commonly, it occurs to the lateral side. And here it is dislocated. Skyline view, routinely used to evaluate patellofemoral alignment with the beam centered on the patellofemoral joint from below. This is the skyline view when the beam is directed from below for the patellofemoral joint, and the knee joint is flexed 40 to 45 degree. This is the skyline X-ray view, the lateral facet here is larger than the medial facet, and this is the articular surface of the patella, lateral femoral condyle, medial femoral condyle, and patellar surface of the femur. We see that the outer surface of the patella is irregular owing to the entry of nutrient vessels here. Merchant view used to achieve patellofemoral tracking with beam directed from above down to a cassette held over the tibia. This is the merchant view, and the cassette here is in 45-degree with the long axis of the leg, and the beam is directed to the patellofemoral joint from above downward. This is the right and the left knee joint by the merchant view. Here we see that the lateral upper outer segment of the patella is separated from the remainder of the bone. Such a patella is called a bipartite patella and must be recognized as a normal and not a fracture. This is in the AP view and in the Skyline view. Fractures of the patella. Transverse fracture of the patella with separation of a fragment by the pull of a quadriceps muscle. This is the fractured segment, and it is pulled by the quadriceps muscle upward. This type of fracture is the comminuted fracture as a result of direct trauma. Ossification of the patella. This begins at 3 years and is completed by puberty. This is the ossification center of the patella. Tibia. The upper end of the tibia is expanded as the tibial plateau. This has an articular surface with a large medial and a smaller lateral condyle, which articulate with the condyles of the femur. Between the condyles is the intercondylar eminence or the tibial spine, which has medial and lateral projections, the medial and lateral intercondylar tubercles. Fibula. Apart from its role in the ankle joint, the fibula is mainly a site of origin of muscles and has no weight-bearing function. It has a head with a styloid process into which the biceps femoris is inserted, a neck, a narrow shaft, and a lower end expanded as the lateral malleolus. Proximal and distal tibiofibular joints unite it with the tibia, and it articulates with the talus and the ankle joint. This is the tibia and fibula, medial tibial plateau, medial condyle, lateral condyle, tibial tuberosity, and this is the head of the fibula, shaft of the tibia, medial malleolus formed by the tibia, and the lateral malleolus formed by the fibula. This is the anterior view, and this is the posterior view. Radiological features of the tibia and fibula. This is AP view and lateral view. Here we see the lateral epicondyle and medial epicondyle, lateral condyle, medial condyle of the femur. This is the intercondylar eminence of the tibial bone, and this is the head of the fibula. This is the patella. Here we see medial malleolus and the lateral malleolus formed by the fibula. This is the shaft of the fibula, and this is the tibia. Knee joint, tibia, fibula, medial malleolus, and lateral malleolus. Here we see the midshaft of the fibula and the shaft of the tibia. This is the ankle joint and the knee joint. Ossification of tibia and fibula. The primary ossification center for the shaft of the tibia appears in the 7th fetal week. A secondary ossification center is present in the upper and at birth, and in the lower end at 2 years. The upper center fuses with the shaft at 20 years. The lower sooner at 18 years. Ossification of the primary center in the shaft begins in the 8th fetal week, and the lower secondary center in the 1st year, and in the upper at 3 years. The lower epiphysis fuses with the shaft at 16 years and the upper at 18 years. This is ultrasound of a fetus. Here we see the tibia and the fibula. This is the knee joint and the ankle joint. This X-ray shows the tibia and fibula, knee joint and the ankle joint. أستاذ نبدي بالكويز.
وياك استاذ رعد وياكم عين.
يلا احنا فرح زهير.
نعم أستاذ. أي هي intercondylar notch.
Excellent. دكتورة تمارا بي.
نعم أستاذ. هذا الليفت فيبيولا الهيد.
Head of the left fibula. دكتور عزام سي.
نعم أستاذ. lateral condyle مع left femur.
Excellent. دكتور عماد حمدي دي.
أستاذ medial prominence of tibial spine.
Excellent. ودكتور أومي أدنى الإي.
نعم أستاذ. This is the joint space of the left knee joint.
Excellent. أوكي عايشة يدي.
أستاذ ما عندنا بعد بس هاي الصورة.
بس هاي الصورة. أوكي.
أي نعم.
أكو أحد عنده سؤال إضافة؟